Good evening, everyone. I'm William Sanderson-Mayer, and this is the penultimate of a series of 5 PPS, Professional Providence Society webinars with UCT's Professor Robin Wood, in which we've been examining over the past 5 months the unfolding research and developments around COVID. Let me just introduce Robin, one of our South Africa's most eminent medical scientists. He's Chief Executive of the Desmond Tutu Health Foundation, a member of the University of Cape Town's Institute of Infectious Diseases and Molecular Medicine, a National Research Foundation A-rated scientist, visiting fellow at Harvard and honorary professor of the London School of Health and Tropical Medicines. He's served and does serve on numerous scientific advisory boards, PEPFAR, the World Health Organization, the International AIDS Society, the International Partnership for Microbiocides, the TB Vaccine Initiative, and the Gates Foundation. Robin, it's clear from the questions and comments that have been coming through for this particular webinar that we've now reached one of the most controversial aspects of the whole series. And I guess in a way one could understand it. I mean, let's face it, epidemiology has never been the most glamorous of medical specializations. I mean, little boys and girls want to be heart surgeons and that nice GP down the road who makes them feel better when they've got the lurgy. But the absolutely critical role that epidemiology does play in our lives has been shown by the pandemic. I mean, it's literally changed the course of nations, and it's affected virtually every person on the planet. Now that the shock and awe has worn off, a lot of skepticism seems to have set in. And I was just looking at the questions. They're all around, are the models fit for purpose? Why are the base assumptions on the modeling kept so secret and apparently inaccessible to those who wish to interrogate the models? And is there a medical omerta, sort of mafia oath of silence, which discourages South African medical professionals from criticizing the modeling of their colleagues? Why don't you tell us a bit about your experience of the whole disease modeling world?
Right, you are. Well, I'm a clinician and not a mathematician, but I have been involved with mathematical modeling of TB, particularly transmission, and HIV, and particularly cost effectiveness modeling of different interventions in HIV. So let me just give you 3 things that I've been involved with, and they will feed some of the skepticism and also demonstrate some of the utility. So the first one would be TB transmission. And I think that to many people, models are intimidating in that they have a series of simultaneous or other equations linking variables, lots of Greek letters, and many medics find that intimidating. But if you, as you say, if you can get to the bottom of what's actually being explored, it can be very useful. So if we go on to the classic model for TB transmission, that's the Wells and Riley from the 1950s. It's essentially an equation, and it's been applied retrospectively to virtually all point epidemics. And the interesting phenomenon about it is that you can get this model to fit all previous episodes, but they do that by tinkering with one of the important variables, which is the infectiousness of patients, and it's measured in the theoretical quanta per unit of time. So the model fits. It's obviously an imperfect model. It assumes steady state, and transmission is often in non-steady state conditions. It ignores the distance between individuals, and it ignores the size of the room in which the transmission is taking place. And yet, so the model is fundamentally not reality, and yet it's actually been quite useful to compare, for instance, transmission in public transport or in Polesmore Prison, which is what we've done. So that's an example of a very rough and ready description of reality, which actually has been quite useful over the years. The second example I'd give is the cost effectiveness analysis. And once you start talking about incremental cost effectiveness ratios, you can basically send everybody to sleep. But essentially on the HIV modeling, the model is actually very well parameterized. It's been calibrated against CD4 counts, viral loads and everything. And then plugged onto that is a cost effectiveness model. And it tells you whether something is cost effectiveness to introduce it. The problem is that cost effectiveness has been defined in an interesting way in order to make it applicable to, for instance, Haiti or to Botswana or to South Africa. So they tie it to the gross national product, the per capita gross national product. And you come up with a number of years life saved against the per capita GNP and say this is cost effective. But the problem is that never take into consideration is the scale of the problem. So if you have HIV with 15% of the population affected, you can have what normally would be a cost effectiveness intervention, which is unaffordable. So there you have a very good model, and the results of it can be not so useful for policy as you might like. And then the last example I'd like to do is one of my hobby horses is the WHO TB model, which is essentially designed to show that treatment is the parameter which is important. And over the years, we've been told in South Africa that we just need to find more patients and treat them. And that model ignores the social component of TB and its transmission. And in fact, I believe it's actually been harmful in that it's diverted our attention away from things like transmission. So you come back to the aphorism which many people quote from George Box is that all models are wrong, but some are useful. And I think that would be very much my view of models.
Okay, so it's a nice quote because it reminds me of the military maxim, no battle plan survives the first shot that's fired. To which Eisenhower's riposte was, plans are useless, but planning is indispensable. Yes. So how, given that we have to have that healthy skepticism, how's the South African government used modelling to direct its policy, or not direct it?
There are several models which have been available, but it seems as though the one model has come from the modelling consortium, which is a mixture of smart young people from not so young, some of them from WITS and Stellenbosch and UCT and other institutions, and they've been put together, and they produced a model which is based on this so-called SIR, where you work on the number of susceptibles, the number of infections, and the number of recoveries in a population, and model what would happen if you did nothing to the COVID epidemic. And then you design the model to see how you can change it from your base case on the basis of your interventions and planned policies. And here they varied the optimism and pessimism of their predictions. So the model was released on May the 6th, which is quite a long time ago as far as this epidemic is concerned. And I haven't seen any updates to that, but one would hope that they have done that. So they peppered their model appropriately with a caveat that these projections are subject to considerable uncertainty and variability, and that's certainly very true. So they had a short-term model and a long-term model. Essentially, the optimistic one was a 60% reduction of transmission by total lockdown, and the pessimistic was 40%. And they had corresponding levels for level 4 and for social distancing. Base case was that by June the 4th, 12 million people would be infected. but they did point out that their numbers of infected may not be represented by the results of the testing program because of inadequate testing or not enough testing, and also the asymptomatic individuals. But they projected in the short term, and their short term was June the 1st, and the long term was November, I think. And they projected 10 to 100,000 cases by June the 1st. That's a pretty wide spectrum, but there were in fact 36,000 cases during that time. So there was a value between their optimistic scenario and their pessimistic scenario. As far as deaths were concerned, they said there'd be between 10 and 600 deaths. And in fact, there were more deaths than they projected. So if we looked at their long-term projection, they projected positive tests of 1 to 2.5 million, and yet we're pretty close to 500,000. So we're much less than was projected for that. And as far as deaths were concerned, we've had 3,700, and their optimistic was 7,000 and their pessimistic was 25,000. Again, massive differences. So it seems as though the long-term projections have been way too high. So reality is about half what they said. So you can interpret that in different ways. You can say, wow, intervention strategies were even more successful than we thought. Or you could say, perhaps the base case was just too pessimistic. And those are the two things. But the interesting thing about the model that I find is that they went on to model the provincial caseload and provincial deaths. And they produced a series of graphs with peaks all occurring pretty early on in the epidemic. And part of the reason for that is the SIR model does actually require an infectious modality transmitting very, very fast. So if you looked at their provincial thing, I find this is the most interesting, that they projected the epidemic looked largely as though it was dependent on just population size of the provinces. But the interesting thing I found looking at the data is there are 4 provinces which didn't actually produce any of the curves that they projected. Projected. So Mpumalanga, Limpopo, Northern Cape, and Northwest actually represent 25% of the South African population. And they, let me just look at the numbers. They basically have an incidence rate of about 1/4 of the Western Cape. But the interesting thing is they have a case fatality rate, which is also 1/4. So it seems as though they're sort of a 17th of the risk of the Western Cape. So as you look at the South African epidemic, it looks as though the case load and the mortality decreases as you go north and west. So is that likely to be right? Or is it just that reality has been misconstrued? Well, if you walk across the border from Northern Cape to Namibia, you'll walk into a country that's only had 16 deaths. If you go across from northwest to Botswana, they've only had 2 deaths. So it does look as though some of the basic assumptions of the model, that the RO number is the same in every province and that everybody is equally susceptible to this disease. I think this model's shown that, and subsequent data has shown, those are wrong assumptions, that perhaps the difference between countries and the difference between provinces in our own country are not explained totally by the implementation of the non-pharmaceutical interventions. So I do find that a model which seems as though it's missed the mark as far as predictions are concerned, and perhaps had too severe a base case, has actually given us a little bit of insight into what might be happening in our population.
Robin, when you talk about these differences between provinces and populations, I mean, obviously models need to mimic likely human behavior, because we can be damn sure humans aren't going to obey the models. So, I mean, surely are models limited by cross-cultural differences? I mean, there is a difference between mask wearing in Texas to patterns of mask wearing in Taiwan, or as regards social distancing practices, taxi drivers in Soweto, as we know, are not as rule-bound as those in Berlin. So how does cross-cultural differences come into modeling, or do they not form any part of that? And maybe you could also just tell us about other models in other countries and how they've informed policy.
Yes, I mean, you can make models increasingly complex in order to take into account all the factors that you've said. There are some limitations in that there are hardly any social interaction studies and data available for the South African population. So I didn't actually mention the South African model uses its mortality data from the early Chinese data. And it makes assumptions very much like the Western assumptions. But if I were to look on a more positive note as to where I think models have helped, I'd probably go back to early days, February. This is just after the epidemic had escaped, as it were, from China. There was the London School model, which was titled Feasibility in Controlling COVID-19 Outbreaks by Isolation of Cases and Contacts. So this was a very early study, and I think it did have some influence on some national policies. And I think essentially my interpretation of it, it really was an elimination model. And what they showed was that at that time, the RO number was a little bit up in the air. So they modeled 1.5, 2.5, and 3.5 RO numbers. That's the number of the ratio of cases, secondary cases to primary cases. And what they showed was if the RO number was low, then all you needed to do was find 20% of the cases with your testing and isolation strategy. If it was around about 2.5, which is probably more realistic for this disease, that you'd need to identify 70% of the transmitters. But if you had a 3.5, you'd have to find 90% of the transmitters. They also found that there were some unknowns, such as the time from initially being infected to presenting with symptoms, and the time of presenting from symptoms to being isolated, and the proportion of transmission that came on before it was recognized with symptoms or else asymptomatic. So that really, I think, informed some national policies. And I think mentioned China, that they isolated not only the cases, but the suspect and the contacts as well, and took them out of their household. But other countries such as New Zealand have been relatively successful. And what it shows is that policy can work for elimination when the numbers are small at the beginning of an epidemic. Once you've got an established epidemic, the resources you'd need to test and isolate those proportions of cases would be very difficult indeed. So New Zealand achieved it, but it is an island, and but they've had one COVID death, I think, in the last 3 months. I think South Korea has tried and just come a little bit off the mark, but it's used that strategy, and it has certainly brought the numbers of cases down very low indeed. So they have probably one death a day, that sort of a thing. So I think that model was influenced the elimination strategy, which has been tried in New Zealand, perhaps in Australia, and in Hong Kong, and some other places. The other main model, I think, that's actually determined global policy is the is the Imperial College model, which was led by Neil Ferguson, who probably is one of the most famous epidemiological modelers in the world. And this is a model that really changed the UK approach to the disease. It seemed as though they were heading towards a more Swedish laissez-faire approach, relying on mitigation. But he wrote this paper that really addressed the concepts of mitigation of the epidemic and suppression of the epidemic. And as I read his introduction, I was quite taken that it was the only paper I'd read that made a direct comparison with the 1918 epidemic, and said this was the worst thing to hit humanity since the 1918 epidemic. And it just jarred a little bit. I wondered, why would he say that? He ignored the 1957, 1968, COVID-2, and etc. Why did he pick it? So I delved into his previous publications, and it turned out in 2007, he'd actually mathematically modeled the 1918 flu epidemic. And he quoted at that time that interest in this study is far from historical. This is really important for policymakers when they mitigate future pandemics. So I think that's why he went back to that. And I'll just touch 4 findings from that early analysis of 1918. What he did is found 16 cities in North America, all of which had slightly different trajectories and different mortality, respiratory and influenza mortality during 1918, 1919. And first thing I learned from that paper, which actually surprised me a little bit, is that I think he was assuming an RO number of about 2, so that you'd normally expect when 50% of the population has been exposed, that then the epidemic could no longer maintain itself. But he pointed out that in fact, if you do nothing, you get an overshoot. And instead of being 50%, you can go up to 80% of the population being infected, even if the RO number is 2. The other one he showed that, which is an interesting concept, which is relevant to COVID, is that if the interventions in the city were too strong, that when you release them, those cities got the second wave. So I think he introduced the concept of that. And the key was that these different timing and intensity of interventions changed the shape of the subsequent epidemics. But the one thing that really stuck in my mind is it was just one little line. They said, well, of all this difference between cities, we can only explain less than 50% of it. So that means that his NPIs, non-pharmaceutical interventions, were different between the different cities, but it did not explain the totality of the difference between the different cities. And I think that comes back to what we were saying about the provinces. Anyway, let's go back to his model. And it was the impact of non-pharmaceutical interventions to reduce COVID mortality and healthcare demand. So again, this was relatively early. It was published in Nature in June, but it was released in March, which again was fairly early on in the epidemic. And I think he scared the UK government to death. He pointed out that his base case, 81% of the population of the UK and USA, which was modeled, would be infected. Deaths would peak at 3 months. In the UK, it would be 500,000 deaths. And in the US, it would be 2.2 million deaths, close to 1% of the population. And that it was inevitable that all healthcare facilities would be overwhelmed by a factor of 30-fold. So you can imagine if you're hearing this from a very senior epidemiologist, it would be quite scary. So he then went on to investigate the so-called mitigation strategy, which was to try and decrease to some degree using home isolation of household contacts, social distancing just for the elderly and the vulnerable, but not closing anything else, like schools or universities. And he showed that these horrendously high mortality figures could be reduced by about 50%, but that it would have been at the cost of healthcare system collapse and 250,000 deaths in the UK. So he then looked at suppression, or this is controlling of the epidemic. And here there was a total lockdown. There was same home isolations. Schools and universities were closed, as was the workplace. And in this model, household transmission was about a third, school and work was a third, and then some sort of community transmission was in the rest, was the other third. So they made this sort of usual assumptions of doubling times the infection fatality ratios and those sort of things. But essentially he came back at the end of the paper and said that the mitigation strategy and suppression strategies would require multiple interventions, but that mitigation was going to still result in disasters, and therefore the epidemic must be suppressed as the only viable intervention. And that, I think, has colored all of, or many of the national policies that have been some form of suppression. He came up with another interesting component of the model that showed that utilizing what he'd found in the 1918 is that if you took the brakes off every now and again, you could get a secondary epidemic. If you monitored that very, very closely, you could close it down again. So you could have a series of pushing the brake pedal and releasing as another strategy. The problems with the two strategies are that mitigation needs to be to allow half the population to get infected with the subsequent mortality, whereas the suppression needs to be maintained or on-off until a vaccine is available. So those are the strategies which came out of that model. Oh, interesting, there's a postscript. I found a subsequent model in which they did change some of their baseline, although they don't really admit it, but the case fatality ratio, they found that they should decrease from a 3% to a 1 point something percent. So again, that would impact on their base case that they modeled. But many people feel the base case was particularly scary, and it's almost impossible to check whether it was correct or not, because NPI has been instituted subsequently. One of the studies which I did find quite amusing was one that was criticizing the Swedish approach, and Sweden has been more of a mitigation strategy, although people argue about that. But there were a group of Swedish epidemiologists who come from Uppsala, Karolinska, big institutions, and I think in Holland. And you could get the feeling that they were desperate to try and change the Swedish approach, because they produced a model. And I think this is one of the problems with models. Models are often colored by the beliefs of the people writing them. So they developed a model which said, if Sweden carries on like it does, then there's going to be 69,000 deaths by in the next few months. Subsequently, they've had 6,000 deaths, so a tenth of those. So you can see why skepticism comes into these models. They can be useful. They can scare people, and they sort of have this strange aura about them of, you know, these are mathematical things that we can't question. But some of the results of the models can be very inaccurate and can be colored by the person who's designing the model in the first place. Well,
I guess I think, if I remember correctly, Ferguson was involved in in the modelling for the animal disease outbreak in the UK, and the solution there was just putting down entire herds. So I suppose we're lucky that we got off with. How should we be using our models then to inform future South African policy?
Well, I think you touched on the first one. I think that there has to be an openness. If we're going to scientifically question these models, we have to know what the models consist of. We have to know the code and the approach. I think we need to know when they're being updated. It was a very difficult call to project the next year of an epidemic from the very early data. So that's to be expected. And I think in retrospect, it's easy to, in retrospect, to say we overreacted, but at the time there was a lot of fear, and it was probably the appropriate thing to do. But as time goes on, we need to be seeing that these models are updated. Some of the assumptions should be questioned. I think that this variability between the provinces would suggest that we need to explore, is the assumption of everybody's susceptible? Is the assumption that the reproductive number is the same everywhere in the country? It looks as though we have a very interesting country where it's inhomogeneous, and that allows you to raise hypotheses as to what could cause that. Is it due to the solar radiation, vitamin D, or whatever it is? But it does raise some sort of hypotheses. And I think that just parroting Western models in a African context is probably not right either. But the models need to be updated and checked against reality and modified. But I think perhaps the most important thing is to actually design the models to answer questions which are relevant. I think that when you overestimate the damage of a base case, you know, politicians love it, because whatever happens, they can take credit for the amelioration of the epidemic. I sort of remember when the Western Cape was the most heavily affected province, which it has been, and politically that was because the DA was in charge and not the ruling party. So people look at the models, they interpret them in very strange ways, but I think there needs to be some open debate about these, and particularly some of the more recent models have included the downside of NPI. I know the Actuarial Society of South Africa certainly includes that, and Panda have done. And when that was raised by a member of the MAC, Glenda Gray, she was closed down straight away and publicly humiliated, and attempts were made to start investigations and get her sacked. That is not the way to use science to try and address a very serious problem that we have.
Oh, absolutely. If the whole modelling exercise is an attempt at ongoing adaptation, it's certainly not how it's worked in South Africa. It's been held as a hostage to ideologies and the egos of ministers and the politically powerful. One of the questions I've had, which I think is quite interesting, or one of the observations, is I'll read it to you. During the past week or so, looking daily at the main coronavirus page on Google, which shows worldwide infections, recoveries, and death, I have watched South Africa ride well over the hump of daily infections, that is, new cases per last 60 days. This development is not being well reflected in what government and the media are saying or doing. What do you think of this?
I think that's a real observation. I do track several parameters and use a 7-day averaging, because the cases are reported strangely during the week and not at weekends, those sort of things. But the 7-day rolling average for new cases peaked several days ago, quite a long time ago. I'm trying to remember if I have a record of that, but certainly that's true. The deaths, 7-day rolling average of deaths, is a little bit more complex, and I think that's probably because some of the provinces seem as rather erratic on reporting of their deaths. But certainly if you look at Gauteng, they hit a fairly sharp peak the middle of, I think, last month, and their mortality peaked about 2 weeks later. A similar pattern occurred in the Western Cape, although there's a grumbling on of the epidemic. And I think the same thing is happening with KZN, that I think the case numbers have peaked, but the mortality is maybe, I would guess, going to peak in the next day or two, but it's always difficult to predict the future. But overall, I think the question is right. And it's interesting that I look at the headlines each day, and it seems as though there needs to be some drama in the headlines, and this is not dramatic enough for them. So they always manage to find something, you know, we've reached some threshold or something else. And I think it also raises the problem of context. So when I was just mentioning the 4 provinces which have very low mortality, I think it's about 400 deaths. You've got to remember that that's in the context of 500,000 deaths for the country each year as a normal event. So, you know, those 4 provinces should have had something like 125,000 deaths as an unfortunate but necessary part of life. The deaths and the births have to sort of meet each other a little bit. So the context is exaggerated in some places, and I certainly think for those provinces, it seems as though the burden and the case fatality ratios, if they're true, and that we should be checking those, would mean that they really don't have the same problems that Eastern Cape, Western Cape, KZN and Gauteng have had. And it looks as though the Free State probably has also peaked. So yeah, interesting, but I think there's a lot of nuancing here, and I would agree that looking at this current state, it looks as though we have peaked. But of course, if we change policies, then we may unleash another small or second wave, etc. It all comes down to what is the immune status of people who've been exposed, and we don't have great ways of measuring that. Our immunological tests are not perfect. We don't have easy tests for measuring T-cell immunity, but it's certainly the epidemic is not behaving like the conventional SIR model that everybody's using, to my mind, in this country.
Robin, a couple of interesting questions from Catherine Child, who's the medical writer for Business Live. One can sense in the question the frustration oozing from her pause. But one of the interesting things she says is there are 2 aspects that she finds very difficult with the South African modelling. The one is that there's absolutely no sign that the consortium is keeping up with the evidence. So she said that the long-term model was made in May. They predicted the hospital bed use was only until July 13. And we're now into August, and yet whenever she asks him, when is the model going to be adapted? The answer is, well, when we're ready. And then she goes on saying that even worse is that the model, she talks about the assumptions of infection, that the South African model assumed 13 million people would be affected cumulatively by November. In other words, it predicted that almost 1 in 3 adults, if one excludes children, who even then were known to have it less often, will be infected. Now, she says at that time, the seroprevalence studies were already showing that that levels were not that high. So the model's infection prevalence was already, at that time, clearly out of line with what was already known.
Well, I think the first comments reflect on what we've already said, that openness and updating and allowing scientific discussion of models and the inputs is very important. I have learned over the years that people feel very proprietary about their models, and they don't like them to be criticized. So that's the first thing. The second one that she's mentioning is the fundamentals of the SIR model. I found it jarring when I first heard the WHO say, well, this is a new disease and therefore there is no immunity to it. Which, you know, at the time I thought, well, how do we know about that? It's another coronavirus. I think there has been some data to show that T-cell immunity may cross from other coronaviruses, and certainly is long-lived in SARS-1 survivors. So, yeah, I think it was right at the beginning of the epidemic, we had to do something. We had to get some sort of assessment of what's the likelihood and react to them. But subsequently, I'm skeptical that the whole population is equally susceptible. None of the curves that are shown by these models look anything like the models of countries or South Africa or even provinces. So there are approximations, and you have to ask yourself, what's the useful thing coming out of the approximations? And I think it's fairly limited. I think the projections for the future were well thought, the best motives to try and get those, but they have resulted in misallocation of resources. The concept that we would be overwhelming all health facilities under every scenario, and I'm aware that in Cape Town, we hardly use the ICC hospital. The mortuary, extra mortuary facilities in Gauteng have hardly been used. So that's, I don't think we want to apportion blame for that, but we made mistakes. I don't see anything now moving us forward with a new vision of the questions to answer and the way forward.
Your comments about the provincial differences have aroused a lot of interest. And I'll just lasso some of the questions together. Elizabeth Murray says, is the lesser infection rate in the north and the west accounted for by younger age, so fewer comorbidities? And then a couple of anonymous questions. You talk about the difference between provinces. How does it correlate with weather and sunshine? COVID hit Western Cape in the rainy season, while the northern provinces have warmer and sunnier winters. Whereas someone else asked, you need to have worked in some of the provinces to appreciate how inaccurate their data may well be.
So can you get a lot of questions there?
Yes.
If the data is so inaccurate, then we should be setting up sentinel sites to get decent data if we're going to try and seriously address this epidemic. I do find it difficult to explain the difference in the case fatality rate. So if you don't test, you won't find cases. But if you do find cases, it seems as though the case fatality rate in those 4 provinces is about 0.08%, as opposed to the Western Cape, where it's 3.4%. But interestingly, the question about the geography, if you follow that case fatality rate north, and the Western Cape and the Eastern Cape very similar, but if you go to KZN, if you go to Gauteng, as you go further north and further east, so that case fatality ratio changes. So I guess it could be that reality has been misdescribed by the data, but I actually don't know how that would happen, because if you don't find the cases, you're unlikely to find the death rates of those cases. And then, does it fit with sunshine? Yes, it does. Interestingly, if you get I played around with this. You get a South African map and look at photovoltaic potential of the different provinces. It does fit very nicely. But of course, association doesn't mean causation, but it does create hypothesis generation. And one could imagine that vitamin D status in the south of the very southern tip of Africa is more prevalent than elsewhere, than further. I mean, this is basically the reason why the mutation for white skin occurred when populations moved into the northern temperate zones in order to, well, we think, in order to largely produce vitamin D. The other comment on age distribution of the different provinces, I think it's very good, very interesting. And why haven't we got that data? Why haven't we got the mortality data by age? And then we could explore those hypotheses. But it certainly is a possibility. But we should be able to discuss these and scientifically look at them. But I don't find that data available.
Gareth Cantor asks, do any of the models look at morbidity, including longer term effects of illness, which apparently may be considerable?
I'm not aware of the models that do that, but I think, as I said, I think models need to be designed to answer specific questions. It's correct that this is still a very young epidemic. And you know, the peak that we're talking about in the country was relatively recently. So looking at long-term sequelae is important. So we need to observe if that really is happening. And it's a perfectly reasonable question, but I don't know that there's any benefit at the moment for modeling something when we don't have the basic data. So I think models, when models go wrong, it's usually because there's another factor which hasn't been included in the understanding of the natural history of the disease. And there are some unusual things about this disease as to why it is so age-related, why it's so obesity and diabetes associated. So it's telling us something about the natural history of the disease. But again, we need as much data as we've got. We need to produce models to better understand different options, look at the factors which are driving the epidemic is sensitive to.
Talking about the actual statistics, there are 3 questions relating to that that are quite interesting. How Marty Schlemmer says, how accurate are the reported figures? What about all the excess deaths that do not correlate to reported number of deaths? And then looking at the reported number of deaths, Darren Martin says, the drop in daily cases is at least partially attributable to the public labs over the past 3 weeks, almost halving the number of daily tests. And while Harry Moultrie says, private lab testing has also declined massively.
Yes, so let's talk a little bit about the testing. If you follow the positivity rate of tests with the 7-day rolling average, it's a very smooth curve, which is decreasing from about 30% downwards. You'd imagine that if testing was decreasing significantly, that it would be more focused on the sicker patients, but you know, I know certainly in the Western Cape at one stage, if you were under the age of 50, it was very difficult to get a test. So there are biases in that data, but I tend to always believe nice smooth curves and very skeptical about things which have a lot of noise in them. So the question about the accuracy of our data, certainly death data, I think is absolutely valid. When I was referring to the paper that was done retrospectively of the 1918 epidemic, they chose those 16 cities because they did have reasonable mortality data, and the mortality data that they included was pneumonias and influenza deaths. Certainly people have looked at excess deaths as another measure. So there's no doubt that we're trying to distill out some messages from inadequate data, and that data is inadequate not just in this country but everywhere. I mean, it turned out in the UK that they weren't counting deaths out of hospitals that were occurring in old age homes. So standardization of data, comparison of data, quality of data are all things which are really very important. And when you can't do them at a large level, then you should set up sentinel sites where you do it well in order to try and get a clue as to what's going on.
There's been a question, Nature ran an article last week around quoting Juliet Pulliam, of the director of the South African Centre of Epidemiological Modelling and Analysis at Stellenbosch, saying that there would be 13 cumulative infections by November, and quote, "We're already breaching capacity in some areas, so I think our best case scenario is not a good one." Well, that seems to be completely contradicted by what we're seeing in the data at present.
The answer to that is yes. I agree with you. You know, the Western Cape has been the most heavily affected province, and we did not overwhelm our health systems. There was a lot of planning. They did take cognizance of the problem, and they built extra capacity, etc. But we seem to be the worst affected, certainly early on, and we didn't overwhelm 30-fold our health facilities. Yeah, again, if you put it in context, it's quite interesting that we deal with 63,000 TB deaths a year, but we deal with it in a slightly different way, in that they don't consume ICU and hospital beds, whereas this disease does seem to do that. But I think the overwhelming of the health systems for South Africa certainly doesn't look as though that's occurred to date. It doesn't mean that if we stopped doing anything that it wouldn't happen, but I think that it seems as though the pessimistic view feeds into certain people's, I don't know if it's beneficial to them or something along those lines, but whereas initially when we didn't have the data, it was an appropriate response to think, well, what's the worst thing that can happen? But as we're getting more and more data, I think that we have to refine and try and explore strategies. And I mean, there are some other, there was an interesting Cape Town model that I think was looking at, can we improve and decrease the resources required for case finding and isolation using electronic cell phone type technologies. So, I mean, all these things need to be looked at and evaluated, but we do need to get good data.
A lot of what you said has gone around the idea of how one uses the modeling, not as a religion or as an ideology, but as a practical tool. Avi Receiver takes us up and talks, I think the use of models for scenario planning is far better than using them to predict what COVID-19 would do. Would you agree? And then second question of hindsight, would you say it's been a wise approach for governments to rely so heavily on models to determine their response? To which one must add, I mean, if they don't rely on models, what do they rely on? Politicians do have to at least cloak their actions in some kind of legitimacy.
So just remind me, the first part of the question was related to...
perhaps scenario, to use models as scenario planning rather than actually as a prediction.
Absolutely. I think that I started off by describing a model which was retrospectively fitted to data in order to answer questions or to do with ventilation, etc. So I think, yeah, models need to be designed to answer specific questions. I think that they're always problematic when they're trying to predict long-term future trajectories of the epidemic, and to be truthful, you know, modelers were asked to do that and they got it wrong. That's almost natural. So I think it's a highly risky thing to try and predict the future. But I agree with the comments, with the with the initial comment that scenario comparisons seem as though they're much more useful. And the first example I gave you of the elimination strategy, I think, showed how models could focus and inform strategies, rather than try and predict the future.
And then, of course, there's the issue of the economic damage. Robin Cruz says a Swedish example suggests we should be far more skeptical and that the economic damage has been hopelessly underestimated. Of course, that's been picked up by the PANDA analysis and also by the South African group of actuarial scientists. To your knowledge, do their modelling attempts feed in any way into how the advisory committees are advising government?
I would have to admit that I'm aware of the overall results of those models. I haven't looked at the specific way the models have been analysed in those particular cases. I know that the PANDA does project a much lesser burden of disease than the others, and I know that they have taken into consideration the potential damage. It would seem common sense would suggest that when you put large numbers of the population out of work and in an already poor population, I think that, just to sort of make a comment here, I think the provincial differences, some people have said maybe they're not real, but I think they are real. If they are real, it would suggest that perhaps a national policy is not the best way to go. If you've only had 34 deaths in your province, then a total shutdown and a destruction of your economy may not be the right thing to do. And if we were going to try and reintroduce some levels of normality, it might be wise to do it at a sort of more local or provincial level in order to inform our way out of this. So I think that either we're completely wrong on the data that we're collecting in the vast proportion of our population, in which case we're in real trouble, or if it is true that there is a major differences between the provinces, then I think that more emphasis on provincial modelling might be wise.
That is really interesting, because when soon after the first lockdown, the government's in Ramaphosa's second speech, he spoke very much around the idea of making having regional policies as information, as data became clearer, that so the government could respond with far more flexibility. But despite those good intentions, we shouldn't just blame the epidemiologists for this. The politicians are not perhaps using the data with quite the flexibility that they could.
Is that a question?
Not really. Sorry, Robin. I couldn't resist it. Here is a question. Adrian Kreusch says, how much do you think fear and self-isolation have affected the modelling and the actual numbers we will eventually see?
So that's a concept which I didn't say had been brought up, but it was brought up in the 2007 paper looking at the US cities, that they were aware that humans' behavior is such that when people around you are dying, that you modify your behavior regardless of national policies. So this is an interesting point. How do you measure that? They do put it in some of the models to look at, but it's certainly a real human response. I mean, you see it going back to Black Death. Certain villages closed down in 1918. Some small communities closed themselves completely, and then they got infected by the postman. So these are human responses, and essentially within South Africa we have a dearth of social interaction data with which to inform these models.
I think this is probably the final question. We have very many more questions, but let me ask the Gareth Cantor again. 30 to 50% of people appear to have cross-reactive T cells. Some people extrapolating this to say regions with 20% COVID-19 prevalence are at herd immunity rates now.
I think that's an interesting question. I mean, the numbers that we're seeing never seem to fit the base case SIR model. So that means that either we've miscalculated some other factors, but one of the ones that strikes me as though it probably is key is a variable susceptibility to this disease. And I agree. I think that's highly likely. And we don't understand the immunology. T-cell immune tests are more laboratory and are unlikely to be point-of-care testing, whereas antibodies are relatively easy to produce, and there's several of them on the market at the moment. But whether they are representing true immunity, there's still a little bit of debate about whether individuals can be reinfected. It doesn't look as though the data is supporting that. But certainly if immunity wasn't fairly strong, then we would expect to get annual epidemics of this disease. If it is T-cell, long-lived T-cell response, then there's probably certainly an end to this if herd immunity was allowed to develop to a sufficient degree, or if we do have a vaccine that would be enabled to produce artificially that population immunity. So yeah. I think
Thanks, Robin.
The bottom line is it's a field which is really interesting, but we're getting data fed to us at a very early stage, and we don't have definitive answers.
Thank you very much, Robin. I don't think we can continue any further. There's one more PPS webinar in the series in a fortnight's time, and thank you so much for a fascinating elucidation of what's happening to us and why it doesn't look like some people think it should look like.
Thank you, William.